So I'm the CEO.
CEO, right, perfect, got it. Thanks.
We're live now.
And that's perfect. That's us going live. Hello everyone, I hope you're doing well. Welcome to our final Mind the Bleep webinar in our FY1 Survival Guide 10-part series. Before we start, I'm just going to welcome Phil, who's actually the CEO of Medal, for a quick talk.
Thanks so much for having me, Nihal, and Hamza, and Chris. It's a real pleasure to join you this evening. And I just wanted to share a little bit about the work that we're doing at Medal and why we're doing it, and to give you a little bit of background to this platform that you're on, but more importantly, the community that you're a part of. Our goal and our mission at Medal is to make healthcare training accessible for everyone. And my background is as a medic, and this is born out of some of my own experience in healthcare training. We need to train 18 million more healthcare professionals by 2030. This number comes from the World Health Organization, and it's been termed as a workforce crisis in healthcare. In context, we need to train a third more healthcare professionals than we currently have on planet Earth. And that poses some problems. Why? Because it's expensive and it takes a long time to train a doctor. It takes 15 years and up to $700,000. And coupled with what the Lancet describe as severe institutional shortages in our healthcare training capacity, poses a toxic combination. And for us at Medal, we really wanted to solve some of these problems. Unfortunately, where the need is at its greatest, resources are at their least. So there are 11 countries on the continent of Africa which do not have a single medical school. There are 24 that only have one medical school, undergraduate or postgraduate. But it's not a problem that's just limited to low-income countries. We actually see the results of inequitable healthcare training in high-income countries as well. Just this week, we've seen in the news in BBC about how we're facing the worst staffing crisis in the NHS's history. But that's replicated across the US and Australia and many other high-income countries. Germany requires 100,000 additional nurses by 2030. India requires 3.9 million additional healthcare professionals to power what they're terming the greatest move towards universal healthcare the world has ever seen. China required hundreds of thousands of obstetricians to simply relax its single-child policy. And all of that takes time and money. And unfortunately, even in high-income countries, a lot of that comes out of individual trainees' pockets. This is a study from the Association for Surgeons in Training in the UK. It talks about the costs of completing your training, CCTing, in surgery. And it talks about the cost of up to £26,000 or £71,000 if you're an oral maxillofacial surgery trainee in the UK, much of which is out of pocket to the individual doctor. And this, coupled with the reduced buying power of our salaries as healthcare professionals over the last 10 years, up to 10% in some cases, poses another problem. And so that's why we're doing what we're doing. We want to make healthcare training accessible for people who live in rural parts of the UK, for people who live in low-income countries, for people who live in middle-income countries, people who live in high-income countries but simply can't afford to travel for the best courses and conferences. We don't believe that healthcare training should be based on who you know, where you live, or how much money you have. And we're passionately trying to solve this problem. And the way in which we believe that that's best done is working together as a community. Rather than all of us doing our separate things disparately, we believe there's real power in doing this together. It means that I, as a healthcare professional, can find teaching and training that I can attend really easily. For organizations, amazing organizations like Mind the Bleep, Learn with Nurses, British Association for Pediatric Surgeons, ENT UK, all of whom use Medal to power their teaching and training. For those organizations, actually reducing the administration on their side is really important. Instead of setting up an Eventbrite plus a Zoom plus a Google form plus a certificate link plus downloading things plus re-uploading things to a video website, reducing that administration so that it is just automated in a single place means less time on administration, more time doing teaching and training. Instead of having to pay for significant Zoom licenses to hold more than 100 people, actually, we're really proud that we can host up to 10,000 people, and we've already reached that 108 number on this call alone. So this would have cost this organization money to run this teaching and training session. We believe in making free and open access events, free and open access on our technology at no cost to that organization. Only by working together can we really begin to solve some of these big problems. This is something that Dr. Tedros said, he needs no introduction, at a tech conference actually a couple of years ago. Ask yourself every day if your technology works to help the poorest in the world and reduce inequalities. And it's one of the things we're really passionate about here at Medal. And that's why we also introduced On Demand. So the organization doesn't need to download a video and actually add it somewhere else. They can, with one click, actually make this webinar available on demand. Why is that important? Well, actually, if you live in a country that doesn't have an amazing broadband connection, or if you do live in a country that has an amazing broadband connection, but you just happen to live in a rural part of that country, like I do, then actually being able to watch at a time and an internet connection that works for you is really important. And so we really have prioritized on demand as well. What does that look like? Well, we're really proud. Over the last 12 months, we've helped 1,300 healthcare organizations deliver over 5,000 free and open access training sessions. And more importantly, those organizations have come from 20 countries, but they've been teaching healthcare professionals in over 170 countries. Many of those countries don't have a single medical school. This has a real impact, but does it work, right? Does virtual healthcare education actually work? This is going to one extreme, right? Obviously, lectures can have an impact, but we actually were really amazed at this paper, which was published by Matthias Ferravari and David Knott's team from the David Knott Foundation at Imperial College London. And what they actually did, without telling us, they actually picked up Medal and started using it to deliver a basic surgical skills course online. And they compared that with running the same course face-to-face. They assessed the competency of attendees afterwards. And the conclusion in this paper was there is no statistical difference between the attendance's competency, whether they attended a basic surgical skills course, moving their hands. I was amazed. I come from a surgical background and I didn't believe myself this was possible. But these guys have actually studied it and found that there's no statistical difference in a really well-powered study of people who are attending face-to-face versus online surgical teaching and training. Even more excitingly, their conclusion was therefore that this sort of technology has the opportunity to scale up the number of global surgeons that we can train. This has a real impact on global health. And they not only did that for one or two people, but what they actually did was they trained over 500 surgeons in 20 countries with a single course. And that just blew us away. I want to tell one last story, and then I'm going to hand straight back over to Nihal and the team for tonight's amazing session. The other impact of this is it actually blew us away. As you'll see on the right-hand side, we actually verify people as Medal verified members when you're joining an event. It means that we can keep this really safe. It means that organizations can genuinely make their event open access without any of the risks of spam that you see on other video platforms. And we verify people using their healthcare email address or ID. And we occasionally, a few times a week, get people who reach out for whatever reason to say they can't verify themselves, and we usually try to help them as best we can. And in one day, we actually had kind of 100 people kind of reach out and say, like, I can't verify myself to join this session or join the chat. And so someone on our support team actually reached out to them and asked why they couldn't verify themselves. And they said, well, I'm a Ukrainian medical student and I have actually had to leave the country and I don't have access to my university emails. And actually, I didn't think it was that important for me to get a letter from my healthcare institution to say I can join Medal. Thanks very much. And we were blown away at what an organization had actually done. They'd picked up Medal and started to teach and train Ukrainian medical students on behalf of the Ukraine Medical Schools Council whilst the war was happening. They'd not only done that with one or two teachers, but they brought 250 volunteer teachers from the UK together to train 2,000 Ukrainian medical students 7 times a day, every single day. That's awesome in and of itself. But what they were actually doing was freeing up professors on the ground, medical educationalists on the ground who were trained medics to no longer have to provide face-to-face medical education, but instead provide face-to-face patient care to people on the ground. And this is what one of those colleagues of ours said. Thank you for everything you're doing for the people of Dnipro and for all people who are trapped in this situation. This sort of technology, this sort of collaboration, when people are working together, that was an amazing organization called the Crisis Rescue Foundation, who'd actually brought 250 doctors from around the UK together to actually teach and train. When we do that, when we have that form of collaboration, when we're together as a community, we are powerful and we can make a real difference. We need to train 18 million more healthcare professionals by 2030. Our goal is to use technology like this to enable us as a healthcare community to do that. And we only believe that by working together can we really ever achieve that aim. If you want to host an event, you can do that, medal.org/host. You can run your own teaching and training sessions, open access, and welcome up to 10,000 people to each session. If you want to find an event to join, well, you find tonight's, but medal.org/events, you can find an event to join right there. You can watch any event on demand, medal.org/on-demand, and watch at a time and an internet connection that suits you. You can still give feedback and still claim a certificate if the organization adds those to their on-demand events. I'm going to leave you with one quote, which is from a wonderful person called Sarah Fryer. She is the CEO at Nextdoor. She was on the board of Slack. In fact, she still is on the board of Slack. She's on the board of Walmart. She was Jack Dorsey's CFO, and she's backed us from day one. Her brother's an anaesthetist in Scotland, and they really believe in making healthcare training accessible. And I'm going to leave this one quote with you, not to blow our own trumpet, but because there's 2 words in here that really mean something to me. And it's the Medal platform has enabled and empowered, those 2 words, enabled and empowered the medical community to deliver medical education at a scale never before imaginable. And if we can get that right, if we can not make everything about us, we don't want everything to be about Medal, we'd rather empower and enable the amazing healthcare organizations who are already doing awesome teaching and training, like Mind the Bleep. If we can simply enable you guys and this community to make your healthcare training easier and more accessible, then we really can scale up the amount of healthcare education we can deliver and make it accessible, free and open access around the world. Thank you so much for letting us join this evening just to share a little bit about our heart and our mission. And I'm going to hand straight back over to Nihal. And I hope you have a really awesome teaching and training session this evening. Thanks for letting me join.
Thank you very much for that, Phil. Medal's certainly doing an amazing job. And the best medical education platform that I've used. So thank you for supporting us and supporting Mind the Bleep.
It's a pleasure. Thanks so much.
No worries. So now we're just going to play a short video from the MDU, who are our sponsor tonight. So Hamza, are you okay to play that video for us?
Yeah, sure.
Thank you.
Yes. Okay.
Yep, so thank you for our sponsor, MDU, today. Unfortunately, their speaker couldn't be here today, so we've just played a video instead, but thank you. Now, without further ado, today's talk is on managing the deteriorating patient. It's going to be delivered by Dr. Chris Peet and Dr. Chris Penney, who are both medical registrars. Just a reminder that this webinar will be recorded and uploaded to Medal and the Mind the Bleep YouTube channel. Please remember to ask any questions you guys have in the chat. We'll make sure to answer them all at the end. I'll also be available in the chat to answer any questions throughout the webinar. Remember, we'll also post a link for feedback form in the chat at the end of the webinar, which will enable you to get a certificate of attendance, which you can use for your FY1 portfolio. So without further ado, I'll hand over to Chris.
Thanks, Nihal, and thanks, Phil, for talking about this platform. It's very interesting. I've not come across it before, and it's great to see your vision on collaborative medical education. So I'm just going to share my screen and then bring up the slideshow. And hopefully you can all see that. Now, I can't see the chat while we're doing this, so if there's any questions, then if Nihal or someone can just let me know and try and answer those. But I think at the end of the talk between myself and Chris, we'll answer questions mainly at the end. So we've been asked to speak to you today about the deteriorating patient. And the talk's going to be split in two, so I'm just going to give a bit of a background, and then I'm going to hand over to Chris, who will give some specific examples and some case-based studies. So, my slides aren't advancing. There we go. Okay, so just a brief overview to begin with. So essentially this talk mainly is about how to assess patients that you come across generally on call, or maybe when you're on the ward, who are unwell or deteriorating. And this was one of the main things that I was worried about when I was just starting out as a doctor, being on my own and seeing someone sick and what to do. And it will give you a bit of a sort of standardized way of seeing these patients and things to look out for. So the first part of the talk, I'll talk about recognizing the deteriorating patient and how to manage them. We'll talk about prioritizing tasks. So what things do you need to do first? What things can wait? And then how to escalate your concerns briefly. And then some examples, which Chris is going to go through. And things that we won't cover today, really, because it's far beyond the scope of this, is how to manage every potential medical problem, as I'm sure you're aware. That's your entire degree. And also, because of our backgrounds mainly in medicine, we're not going to talk about specific surgical, paediatric, or obstetric or gynecological problems. So actually, slight change of order, but we'll talk about prioritizing tasks first. So, common scenario, you'll be on call covering the wards, and either in the daytime or the night time, and you'll get a bleep, and they'll just want to let you know something. Now, usually, most people will have been taught some sort of way of handing things over or escalating concerns to you, but often you'll need to prompt people who are calling you for specific bits of information, which will give you some guidance as to how sick you think this patient is, how important this job is for you to prioritize. And you'll almost certainly always be asked to do more things at once than you can possibly do, and you need to come up with a bit of a strategy as to how to focus on the ones that are important. And really that involves, first of all, is it a job that you yourself need to do, or is this a job that you can delegate to someone else? And is it a job that you need to drop everything for and do right now, or can it wait until later? So I was actually on call over the weekend on nights, and in our hospital we had quite a lot of staff shortages, and there was no ward cover FY1, and there was no ward cover SHO. So I was basically holding the F1 bleep and the reg bleep for the ward. So these are some of the things anonymised that I got asked to do. And I just want you to take a quick look at all of these jobs and sort of see if you can pick out the ones that would make you most worried, and which things you think actually probably aren't important to do at 3 o'clock in the morning when you've got lots of sick patients to look after. So they range from someone being short of breath and needing to be started on oxygen, someone needing some fluids, someone who's not had their regular medications prescribed, someone who needs a discharge summary writing because they're going to go home at 8 o'clock tomorrow morning, and various tasks. So I hope you can see that the ones that stood out to me anyway are these ones in red. So as someone who's short of breath and needing oxygen, potentially is acutely unwell. Why are they needing oxygen? Why, what's going on with this patient? We need to go and assess them as a priority. And then also this gentleman, Mr. Jones, that the nurse can't wake up, and I appreciate it's 3 o'clock in the morning, but usually if they can't wake someone up, that could either be they're asleep or it could be that they're unconscious. So that's something that you need to prioritise as well. And a point to make here is actually if you get called to see these two patients at the same time, you can't be in one place in two places at one time. You might need to ask someone to help you. So if you're on call as part of a team and you've got an SHO working with you or a registrar working with you, and you need to see these two patients at the same time, it would be good to contact your colleagues and see if they can help you out. And this is just you've probably seen something similar to this before. It's a sort of decision matrix that you can use to sort of prioritise tasks. And it could be used for anything, but using it for jobs that you get asked to do while you're working on call. And you can see that in the top left there, the category is tasks that are urgent and important. And these things you always need to prioritise and do first. And some examples there, reviewing someone who's got a high early warning score, chasing a scan for a patient who's fallen and is more drowsy than normal. All of these things are quite urgent things, but they're also very important because they can involve harm to patients if they're not handled properly. Moving across onto the right-hand side, still important jobs, but less urgent, so not things that are life-critical, but important nonetheless. And these are things that you need to decide when you're going to do them, what order they need to be done in, how far down your job list can they go, and things like prescribing pain relief for patients is important, but is there something that someone can do in the meantime? Have the nurses given some medications that are already prescribed while you're on your way? And so that's something you can decide on. And then onto the bottom row, so things that are not important, and not things that aren't important but are potentially time critical, things that you can generally delegate to someone else potentially or defer to later. So an example is updating a patient's relatives. That is important because that is urgent because the patient's relatives are not going to be there the whole time, but it's not necessarily something that you need to do if that patient's stable. Can the nurse who's looking after the patient update the family and give them a generic overview of what's going on with their relative? And similarly for a routine cannula in a patient who's not unwell or unstable, has anyone else tried to put that cannula in? Is there a senior nurse on the ward who can cannulate patients? Can they go and do this job before you attempt it? And then finally, things that aren't important and not urgent, I would suggest you don't do. So the example that I had on my previous list was doing a discharge summary for a patient at 3 o'clock in the morning. I think that, unless you're literally sat around doing nothing and are very, very bored, then actually, that's not something that you need to be prioritising. And there are some caveats to these things. So, sometimes you'll get asked to do something because someone's just worried about a patient. Now, that can sometimes, on the surface of it, seem silly, because actually, you can ask them questions about this patient, and all of the information you're getting back is potentially telling you that this patient might be well or might be stable. But actually, sometimes, very senior nurses working on wards have experienced all of this before, and actually their intuition can sometimes give you a bit of a clue as to what's going on. So that's something that might make you more suspicious about what's going on with a patient. And not all patients act in the same way. So we know that patients who are very young or patients who are very old have different physiology and will react differently to an insult. And so, an older patient may not score a high early warning score on their observations, so they might not sound too unwell over the phone, but they may actually be very unwell when you go and see them. So these are all things to sort of bear in mind. And sort of on the flip side of the first point, not everyone is as skilled as you will be at picking up whether someone's sick or not. You actually probably need to go and see these patients yourself, in an order of priority, so that you can make a decision about whether they're unwell or not. I won't take any questions just yet, because I think we're going to probably go through everything at the end. But that was just a brief overview of how I would prioritise jobs, and prioritise finding out which patients are deteriorating and who to see first. So the second part, we're going to talk about how to assess a sick patient and a deteriorating patient. So I use a generic approach, and I'm sure you've all been taught very similar things in your training so far, and maybe you've done simulation training, and maybe you've on the wards you've been seeing this sort of thing put into action. So generally, starting out by seeing the patient from the end of the bed will give you a lot of clues as to whether they look unwell. Are they wearing a non-rebreathe oxygen mask? Are they tachypneic? Do they look grey? Are they responding normally? And lots of these things you will just pick up within seconds of looking at the patient from the end of the bed. And it's important at this point, if you see that a patient is unresponsive, or you feel for a pulse or look for signs of life and they aren't there, obviously you need to put out an emergency call. This isn't a deteriorating patient that you should be managing on your own. You need the team there, and you need to potentially be starting resuscitation. If they're not like that, and you're moving on to start examining them, a general approach to your examination should be that this isn't an OSCE, and actually, when you're examining the patient, you're not looking for, multiple different eponymous signs of mitral regurgitation. You're looking for key things that are going to tell you if this patient's sick, what their physiology is doing, what do you think is going on with them. So your examination should be focused, and it should be methodical. So you should be going through things from order of importance, and what's going to kill the patient first, and it should be very quick, because you're trying to get lots of information in one go, and you should also be acting on things as you go, and we'll talk about that in a few seconds. And then once you've done your assessment and you've identified that yes, this patient is deteriorating and they're unwell, and you've started to act on that, it's important to feed back to the rest of your team, whether it's the nurses in the bay, that you need help with enacting some of your treatment plan, or is it actually you're worried about this patient, you need to let your seniors know. And an important point in this is that, myself as a registrar, if one of my team is seeing someone on the ward and they're worried about them, I want to know about it, because if I don't know about it and they continue to get worse, it's something that should have been acted on earlier. And it's not, I don't want to know about it because I want to check up that what you're doing is right. I want to know about it because I want to know who's sick in the hospital, and what's going on. And then once you've identified that this patient's sick, you need to think about what tests you might want to do to confirm this. But it's always important to say that these shouldn't delay your treatment. So if you've examined a patient who's short of breath and you've noticed that they've got a raised JVP, they're tachypneic, they've got crackles at both bases, they've got pitting edema up to their abdomen, they've probably got heart failure. And waiting to get a chest x-ray to confirm that yes, this is pulmonary edema isn't necessary. You should be giving them some oxygen, you should be giving them some furosemide and seeing if that's going to improve their clinical picture while you're waiting for those investigations to happen. So it's important to act on things as you see them, make judgments as you go along. So the generic approach, as you'll all know, to reviewing deteriorating patients is the A to E assessment. And I've taken all of this from the Resuscitation Council guidelines on this, which is the sort of training that you get. Some of you may have done ALS already as part of your medical degree. And if you use this QR code, you can see their PDF online. And it's a good summary, I think, of how to perform a brief assessment of a deteriorating patient. And you can use this approach to all patients, whether they're, in whatever situation you find them, if they've just presented to ED, if they're on the wards, if they're post-surgery. It's a very good, quick, methodical assessment, and it helps you to identify and treat things at each stage of the examination, which are life-threatening, and deal with them as you go along. And it should be brief initially. So, it says here 30 seconds. That's, once you become very proficient in doing it and done it lots of times, but it's not a long examination. You're not there to test every single part of the neurological system. You're there to see if someone's dying or not. And so, treat things as you go along. Don't forget to involve people. So if you're in a bay and the nurse is in the bay, maybe doing some routine observations for the patient opposite you, you need to sort of get them to come with you and say, look, can you be doing this patient's observations as I'm examining them? I need to know what their blood pressure is now. I need to know what their oxygen saturations are now. Involve other people. And if you're struggling on your own, or you need another pair of hands, then call someone. It's much better to have people there, and then you don't need them than it is to realise 10 minutes into what you're doing that actually you needed people earlier on. So always involve people if you need them. And also, you're not there to diagnose things straight away, so you're there to pick up what things are deranged. So it doesn't matter if you can't decide whether this is a pneumonia or heart failure. You need to treat what you see as you go, and then clarify things a bit later. So the first part is assessing the airway. And as you all know, airway obstruction is an emergency. So if you see this isn't something I would manage on my own. It's not something I expect anyone else to manage on their own unless they're, in intensive care and they're an anaesthetist. You generally need lots of people here to deal with this. And signs of airway obstruction. So signs of partial airway obstruction are noisy breathing. So it might be snoring or stridor if you've got upper airway obstruction, reduced air entry, and then complete airway obstruction. You would not hear any sounds, and the patient might maybe cyanosed, and they may have seesaw movement of their chest. So that means when they're taking a deep breath in, their rib cage is moving up, but their lungs can't expand because of the blockage of their airway, and their abdomen goes in as their thorax goes out, and that's paradoxical breathing. And as I said, don't manage this on your own. Put the patient on some oxygen. You may want to perform some airway manoeuvres or put some airway adjuncts in to try and keep the airway patent. If there's lots of, for example, lots of vomitus in the mouth, you might want to clear this out. Take out dentures. Perform some suction and division using a Yanker sucker, but get help quick. So then, to assess breathing, once you're happy that the airway is sorted, you want to look for signs of respiratory distress, and that might be sweating, tachypnea, there might be an obvious chest deformity or unequal expansion, for example, in a tension pneumothorax. Tracheal deviation, so this might be towards the problem, so in a collapsed lung, or it might be away from the problem, so in a very large effusion or a tension pneumothorax. Breath sounds might sound from the end of the bed wet or rattly, or if there's airway problems, or there might be wheeze or stridor. And treatments obviously depend on the cause of problems, but we'll give oxygen to all patients who are having problems with their breathing. And even if you're worried that this patient is retaining CO2, if they've got severe COPD and they're in chronic retention, you're not going to kill someone by giving them oxygen in a short period of time. By all means, target that oxygen saturation if you later get more information, but in the initial assessment, give people oxygen to make sure they're oxygenating okay. And then assessment of circulation. Essentially, here you're looking for signs of shock, which is the inability to perfuse organs, and in almost all cases, it's safe to treat shock as hypovolemic shock. So even if someone's in distributive shock because of sepsis, giving them fluid is going to help that as well. So and you want to find out what the cause of this is. Is there bleeding somewhere, and this could be concealed bleeding, intra-abdominally or into a compartment like a thigh if there's a fracture, or it might be overt. You might see melena or hematemesis. The patient might be pale or mottled if they're peripherally shut down, and they'll be cool to touch generally. They'll be tachycardic, they may have a thready pulse, and their capillary refill time will be prolonged. You may see collapse of their central veins or peripheral veins, and their blood pressure will usually be low but can be normal in the immediate instance of shock, because people get a physiological response to that, and they get an adrenaline driven response, and their blood pressure may temporarily be normal, and then you can look for urine output. So these are all the things to look for shock, and once you've dealt with that, assessing the level of consciousness. So you can use tools like the AVPU score or the Glasgow Coma Scale, and you can quickly assess someone's level of consciousness. So all the way from alert and talking to unconscious. And if you need to provide pain, just be aware that you don't want to cause trauma. So pressing on the supraorbital notch is a way of inducing sort of central pain response, and also doesn't cause much trauma. You always want to check their glucose, because if they're unconscious, even if they're not diabetic, you want to make sure that they're not hypoglycemic. And this is best done with venous or arterial sampling in a critically unwell patient, because often their capillary glucose doesn't correlate very well with their circulating glucose levels. And if they are hypoglycemic, you need to treat that, and in most patients that will be giving them a bolus of IV glucose, and 250 mils of 10% glucose is a reasonable start. Try not to use really concentrated glucose solutions like 20-50% glucose, because that can be quite damaging if it extravasates. And obviously if someone's unconscious, you need to try and maintain their airway. So for example, if the patient has a seizure, always put them in a recovery position while you're assessing them and getting help. And finally, you need to make sure you've examined the patient fully. So once you're happy with the other areas, and you want to make sure that you minimise their heat loss. So once you've examined them, don't leave the sheets off them. Make sure they're covered, because an unwell patient will not control their core temperature very well. So that was a quick overview of an A to E assessment, and I'm sure you've all practiced this before, and it's probably not new information to you. But it is a very good tool to assess a deteriorating patient and deal with what's going on in the immediate assessment period. And once you've done that assessment and you've got a bit of time and you might have put in an action plan and started to stabilise the patient, you want to make sure you know what's going on. So this is where you do a bit more delving in and look at their history, why they're in hospital, look at any relevant observation charts, look at their drug charts. Have they been started on any medications recently? Have we not given them their medications? So the Addisonian patient who's not had their regular steroid prescribed, they could be having an acute crisis, and you need to manage that. So all of these things are important, but things to do once you've actually assessed the patient. And all patients, you want to consider, if they continue to be unwell and deteriorate further, what is their plan for escalation? So is this someone that we should be involving the critical care team with to support their organs on HDU or ITU, or is that inappropriate? If it is inappropriate, do they have a documented plan to say that it's inappropriate? So things to consider when you've initially assessed the patient. And again, probably talk about questions at the end if that's okay. So I'm going to move on to talk about investigations, and I'm mainly going to focus on arterial blood gases because I was asked to talk about that. But I'll give you a little bit of a rationale about using investigations first, because something that's quite important to make sure that you're doing the right investigation for the right problem. And so just telling you to do lots of investigations for a deteriorating patient is not always going to be the right thing to do. And we need to have a little bit of a think about what the important things are. So this was a mantra that was drummed into me by a critical care, advanced critical care practitioner that I worked with. And he always said, don't forget to do A to E before you do an ABG, because actually one of the most tempting things to do when you see a sick patient is to think, I need to know exactly what's going on. I'm going to do lots of tests and figure out what's going on. However, blood gas isn't going to help if the reason the patient's hypoxic is because their airway is obstructed. So you need to do that A to E assessment before you go delving into what tests do I need to do, what imaging do I need to get for this patient. Do the simple things first, and stabilise the patient first. Okay, so the investigations that you want to pick for a patient will very much depend on what's going on with them. And these examples are not exhaustive and they don't cover everything. But, for example, if you're asked to see someone who's acutely short of breath, at the bedside you'll want to examine them and take their oxygen sats. Yeah, you may want to do some blood tests, and that might include an arterial gas to see what their oxygenation is like. But also you might want to do some other blood tests, and if they've got a history that's compatible with this, do you need to take a D-dimer to rule out a PE? It's important that, and I'm sure you've been told at med school, that actually the sensitivity and specificity of tests, very much depends on what you're looking for. And so doing a blanket test for everyone is not a good idea because it can lead to further problems. And then imaging, will depend on what you think is going on. A chest X-ray is generally a good idea. And then for chest pain, similar bedside examination, ECG is important here. Blood tests might include a troponin if they've got cardiac sounding chest pain, but doing a troponin in someone who doesn't have cardiac sounding chest pain might not be beneficial. And then for example, in hematemesis, then again, you'll want to do similar examinations, but you'll want to make sure, where are they losing blood from? Have they got digested blood on PR? Have we got a valid group and save? They need cross-matched blood, and all of these other things that you need to think about that are different to if you're assessing someone who's short of breath. And the list goes on. So these are not exhaustive, but they're just an example of how we need to tailor what we're doing to what we think is going on. So doing an inappropriate test may lead to actually harm for the patient. So if you do a D-dimer in someone who's got, a very severe pneumonia, it's probably going to be raised even if they've not got a PE. So if they don't have any clinical signs or history that would point towards them having a PE, you're still going to then have to do a CTPA on them, and that's potentially an unnecessary exposure to radiation. So it's always important to think about what you're looking for. So we'll talk a bit about arterial blood gas sampling then. So you've probably either done this as part of your training on the wards or been shown how to do it in a simulated environment. So we'll just touch on it briefly. And most patients, you'll take blood from their radial artery because that's the safest way to do it. In a HD or ITU setting, the patients may have an arterial lining which you can just take a sample from. But in most cases, you'll be using a pre-filled syringe, and I like to use a small gauge needle because it's less pain for the patient. And speaking of pain, now in a critically unwell patient who's deteriorating, using local anaesthetic may take up more time than it has benefit to the patient. However, the BTS do say that it will improve your chances of getting a successful blood gas, and it's obviously much nicer for the patient. I've not had an arterial blood gas taken, but I can't imagine it's very comfortable. And certainly, if I was putting in an arterial line, I would always use anaesthetic because there's a bit more time. But I must admit and put my hand up here that I don't routinely use local anaesthetic for blood gas sampling, but it's something to think about in your routine sampling. And another thing that is recommended to be done is doing a modified Allen test, and that's just to check that there's patency of both the radial and the ulnar artery, so you've always got collateral flow to the hand in case you severely damage the radial artery in sampling, maybe causing a dissection or something like that. So that's just you get the patient to compress their hand and you occlude both arteries, and then you open the hand up, and you should see a return of colour to the hand if you open up one of the arteries in turn. So that's just to check that it's safe to sample. And then once you've taken your sample, you should compress the artery for a couple of minutes and make sure you put a decent bandage on it. I usually make sure it's quite tightly stuck down. And then you mix your sample and you analyse it as per your guidance for whatever a gas analyzer is used in your trust. And I'm sure on your inductions you'll all get shown how to do that. So I'm going to briefly go through a way of analysing the results and looking at what's wrong with the blood gas. It's a simplified way of doing it. It doesn't cover all of the weird and wonderful extreme causes of acidosis, and it's a bit of a light overview. But essentially, you want to look at the patient first and see what you think is going wrong with them, because that will often guide you as to what to expect on the blood gas when you get the results. So, first of all, are they unwell? And if they are unwell, what's wrong with them? So, if a patient's got a raised respiratory rate, you may well expect that they're going to be hypoxemic on their gas, or they might be acidemic. So if they've got severe metabolic acidosis, to try and correct that, they will hyperventilate and try and blow off excess carbon dioxide to compensate for that acidemia. If they're comatose, they might be hypercapnic if they've got type 2 respiratory failure, and that's causing them to be comatose. And hypotensive patients, you might well expect to be acidemic if they're not perfusing their organs and they've got a lactic acidosis. So all of these things will give you a bit of a hint as to what you're looking for when you get the result. So firstly, you want to start by looking at the oxygenation of the patient on the gas, and that's by looking at their partial pressure of oxygen. Now, I've written here, it's a simplified physics warning, so anyone who knows this in detail will know this isn't correct, but it's a good rule of thumb, and it gives you a good pointer at looking at gas results. So, on air, with normal physiology, a patient's partial pressure of oxygen should be between 10 and 13, and that's because roughly you can take their percentage inspired oxygen and take 10 off that number, and it will give you what their PO2 should be. And so, for example, a patient who's on 40% inspired oxygen through a Venturi mask, you'd expect their PO2 to be about 30 kilopascals. And that's in the normal setting with normal lungs and a healthy patient. Anything less than that, you'd expect that there's a problem somewhere along the line with oxygenation, and it doesn't tell you where the problem is. Have they got an obstruction of their airway, or have they got a massive pneumonia that's taken out half of their lung capacity? But it gives you a pointer. So then once you've looked at their oxygenation, you need to look at their acidity, and to do that, you look at the pH value that you get on the gas, and anything less than 7.35 is acidemia, and you'll know that acidemia can be caused by a respiratory cause, so raised CO2 in the blood, or it can be caused by metabolic causes, of which there are many, but commonly lactic acidosis, and then if the patient's alkalemic, so that's a pH of greater than 7.5, that could be caused by a respiratory cause, although in normal spontaneous ventilation, that is very, very rare, and we'll talk about that in a second. And metabolic alkalinia can be caused by excess loss of hydrogen ions, so lots of vomiting, for example. Once you've looked at their acidity, then look at the respiratory part of their gas, and by that I mean looking at their CO2 level. And when you look at that, if their partial pressure of CO2 is increased, so greater than 6 kilopascals, then they've most likely, if their pH is low, got a respiratory acidosis. But obviously patients are complex and they have lots of different things going on at the same time, so they may have a metabolic acidosis as well as this, so it might be a mixed acidosis. If their CO2 is reduced, then and they've got a raised pH, then that's a respiratory alkalosis. However, that is, as I've said, unusual unless the patient's being mechanically ventilated and we've increased their tidal volume and their respiratory rate on the ventilator too much. The patient really needs to be properly hyperventilating to drop their CO2 and become alkalotic with it as well. And then when you look at the metabolic part of the gas, and that is looking at the bicarbonate and the base excess. So if they're acidemic, pH less than 7.35, and they've got a low base excess, so that's anything less than -2, and a low bicarbonate, anything less than 22, then they've probably got metabolic acidosis. And I say probably because actually these states can coexist. So what you'll know is that the body will compensate to abnormal levels of acid in the blood. So if someone's got a metabolic acidosis, they may increase the respiratory rate in compensation. So they might have a compensatory respiratory acidosis, and it might balance itself out, or it might partially balance itself out. If they're alkalemic with a high base excess and a high bicarbonate, then they've got a metabolic alkalosis. And this is where things get a bit complicated because they can be both at the same time. But as a rule of thumb, this will probably give you the right answer most of the time. And as I said, in combination with looking at the patient and thinking what is going on with them. So just a few examples quickly. So looking at this patient in ED, they're drowsy and they've got a raised respiratory rate and they've got a background of COPD. And this is their gas. So have a little look at that. It's taken on 35% inspired oxygen via Venturi. And looking at them, they're unwell. They've got a raised respiratory rate, they're drowsy. And they've got a history of cough with sputum. So looking at that gas, they're hypoxemic, aren't they? So their PO2 is low, 6.7, and that's even despite being on increased inspired oxygen. So as we said before, we would expect in normal physiology their PO2 to be about 25 roughly. They're acidemic, so their pH is 7.12. So why are they acidemic? So let's look at the respiratory component. Well, if we look at the CO2, that's raised, so CO2 of 13. So that pretty much gives you the answer. And looking at the metabolic component, their bicarb's low, and that means that they're trying to acutely compensate. And actually, if you see a gas of a patient with type 2 respiratory failure chronically, when they're not acutely unwell and acidemic, their bicarb will usually be quite high, above what you expect, and that's chronic compensation. So the answer is that this patient's got primary respiratory acidosis, and they're partially compensating for this with the metabolic alkalosis, but they're in type 2 respiratory failure. Another example is this patient with diabetes and gastroparesis, and they've been vomiting 12 times a day, and this is their gas on air. So they look unwell, and they're dehydrated, and they've got muscle cramps, and they're vomiting lots. So look at their oxygenation first. So there's no issues with that. They're on room air and their PO2 is 12. That's fine. Looking at their pH, they're alkalemic, so their pH is 7.59. And why is that? Well, look at the respiratory component. So they've got slightly raised partial pressure of carbon dioxide, and you look at them and they aren't breathing, very rapidly. And if you look at the metabolic component, this will give you the picture. So they've got a high bicarb, and their base excess is very positive, and that suggests that they've got a metabolic alkalosis, and they're trying to compensate by hypoventilating. And these numbers are probably, I've made these numbers up, so they're probably a little bit extreme. They probably wouldn't have driven their CO2 up that high, but so the answer is that they've got a metabolic alkalosis from vomiting and losing hydrogen ions, and they're trying to compensate. And finally, a very common picture that you'll see on a gas post-cardiac arrest. So the patient's on 100% inspired oxygen, they're being mechanically ventilated, and you can see that they're obviously very unwell. And looking at their acid picture, they are acidotic with a pH of 6.8, and they're hypoxic despite 100% oxygen, and they've got a raised CO2, so they're probably being underventilated a little bit, and they've got low bicarb, and base excess is very negative, and you can see the lactate's very high there. So they've got a mixed metabolic and respiratory acidosis because they've been, they've had a downtime of say 10 minutes, where they've, despite CPR, have been hypoventilated and hypoperfused. So it was a quick run through, and by all means it doesn't cover everything, but it gives you a good overview of how to assess someone's blood gas, and a bit of a rationale about doing tests. So finally, I'm just going to briefly touch on how to escalate concerns, and just looking at the time, then Chris is going to go through some cases which should be more interesting. So essentially, the key points about escalating concerns is don't ever suffer in silence. Don't struggle looking at a sick patient and thinking, I don't know what to do. Myself, and I'm sure Chris will echo this, when we're the registrar on call, we don't want our team to be feeling like they're not supported, and certainly we would want to be supporting you if there's someone sick on the ward, because we need to know what's going on with the patients. And we all get to a point where we can't make decisions, or we may become tired, and it's important to escalate things in that situation as well. If you get any kickback from trying to escalate your concerns about a patient, that usually says something more about the person that you're talking to than it does about you. We've all been in that situation, and even the person who's becoming a consultant, they get in situations where they need to escalate their concerns, and it's a good practice to get into, is letting people know in an appropriate way about patients who are deteriorating. And I've just put there, some people are rude. People can be snappy, and it's usually because they're tired or they're busy, and it's not something you should put up with. My colleague, when we just started as F1s, once told a very angry and irate consultant that she called for advice to just pause for a minute and talk to her like an adult. And I thought that was brilliant, because actually, we are all doing a job, and don't put up with people being rude to you if you're trying to escalate something to them. And if you think that something's wrong, it probably is, and you're right to be escalating it. So don't be worried about that, and make sure you're not on your own, and you've got the rest of your team around you. So you should always contact them if you need them. So briefly about your team, it will vary depending on where you work and what specialty you're in. Don't forget to use other people who are experienced around you. So a lot of acute on-call teams have lots of other allied health professionals with them, like advanced care practitioners, physicians associates, critical care outreach teams. All of these people you can escalate your concerns to or ask for advice from. And these people have their own strengths and benefits. Most hospitals have, your team will be split into looking after the acute take, whether that's medicine or surgery, and the ward patients. So familiarise yourself with these teams when you start, and who to contact if you're worried about a patient in the area that you're working in. And these are just a brief overview of some communication tools that you can use for escalating your concerns, and you've probably come across them and used them already. So there's the SBAR tool, which is very similar to the RSVP tool that's on the right there. Basically, you're starting out by saying where you're calling from, what's going on, and then a bit of a background about the patient, but that doesn't mean to reel out their entire medical history. And I think Chris is going to go into this in a little bit of detail about actually what is important to get across on the phone. And then your assessment of the patient and what you want to happen. So it's important to get across to the person you're on the phone to. If you want them to come and see the patient, let them know, because sometimes you might just be calling for advice, but actually if you're worried about someone and you want them to come and see them and they've not identified that, say, actually I want you to come and see this patient, and they will do that if they're any good at their job. And finally, getting in touch with people. So if it's a critical problem, put out an emergency call. It's fairly self-explanatory, and in every hospital it will be calling 2222, and that will get you everyone there. Is it an urgent problem but not, a dying patient in front of you? Then in that case, you can put out a fast bleep if you need someone to come to you quickly. Be aware that person will have to drop everything and run to you, but that means that they usually get there very quickly, and you can ask them for urgent advice. If it's concerning, let your registrar know. So this is anyone with sort of deranged physiology, a high early warning score, and ask for help early on. Or do you just need a hand? You've got too many jobs on the go. Then you can escalate to your immediate colleagues, or just talk to them about your jobs list, which always helps. So I've hopefully not taken up too much time, and I'm going to pass over to Chris now, who's going to talk to you about some specific scenarios and how to manage them in deteriorating patients. And then we'll take some questions at the end. All right, thank you.
Right, hello and good evening. My name's Chris Penney. I'm one of the fellow
Registrars currently working at Royal Children's Hospital. I'm going to share my screen now, and we'll hopefully get underway with a few case-based presentations. Chris, can you just confirm my screen? I've got a yellow line around it. Yeah.
Yeah, I can see that. Yeah.
Perfect. I'll just hide this as well. See if it will move. There we go. So I haven't really done an intro as such because we're going to be trying to working through some cases and just sort of picking out some of the salient points about some of the aspects of your A to E that to pick up and how to approach each aspect as we go through essentially. So we'll just jump straight into doing the case. So case one, I'll read out the parts of it, but I'll let you do the in-between bits. So this is based on when you're on your ward cover, as Chris mentioned, where your on-calls will largely be split between being on the take and on the wards. On the take, you can often have a lot of people around you, but on the wards, is much more independent working. So this is where sort of your A to E assessment and your management of the deteriorating patient really comes into its own, because you won't have as many ED doctors and take doctors around you. So Sarah Jones, a 62-year-old woman, admitted last night with DNV. She's had DNV for the last 4 days, and her husband's had it as well, but he feels okay. She seemed fairly well initially, coping with it okay, but then over the last sort of 24 hours, she's become more lethargic, and took her to the GP, and blood pressure was quite low with the GP, and GP quite rightly sent it into hospital, blue lighted her in. Past medical history is fairly minimal, past depression, PMR, and diverticular disease. She's on citalopram and some pred. Not much on the social history. So she's been treated for sort of a query gastroenteritis. Picture, she's had IV fluids, she's had some IV antibiotics for ED because she came in and she was hypotensive, so she was worked out from the sepsis perspective from that side, and her stool culture, blood culture has been sent. So this is really trying to get out your assessment of hypotension. So really, when we're assessing our hypotension, obviously this is moving on to our C of our A to E approach. So we're assuming the A and B are okay. So this is when when you've got hypotension, your causes can be split into having a look at the volume assessment. So these will be on your examination aspect, and you're looking at things such as the cap refill time, the mucous membranes, the JVP. So obviously this is dependent on the positioning of the patient. If the patient is lying supine in bed, then there's not much point in doing a JVP. You have to sit them up for it to be clinically useful to the right degrees. And then peripheral edema. So this is looking at the legs and putting a bit of pressure over the shin bone essentially to have a look. So this is what our current obs and your current call to see her. So she's hypotensive, tachycardic, respirator's a little bit higher, SATs are okay on air though, and she's mildly febrile or just borderline febrile. So what could be going on with Sarah? So when you're assessing her volume status, documentation and layout of your documentation is quite key in making sure that you're imprinting what your rationale is thinking, because if you're on a night shift and you're doing a plan and you're doing this working independently, then your documentation is the key to your rationale of your thinking and why you've done what you've done. So this is sort of just a mock of what I might write if I was seeing this patient. So asked to see hypertension, 62-year-old, admitted with DNV. Quickly write down the past medical history if it might be relevant, or you can just say past medical history noted, or if it's not that relevant, you can leave that bit out. Put down the obs about what's the relevant bit. And then I like to do a little bit split into sort of investigations, so you don't have to pick out the salient points. So this, she's got an AKI, she's hyperkalemic, and the sodium is a little bit low, white cells mildly elevated with CRP additionally. So, and then you've got your examination, and then this is where you want to be thinking about your volume status for these hypertensive patients. So the volume in a lot of these will be a balance between what's going in and what's going out, will determine a lot. So this will be a fluid chart. Depending on where you work, you may have to go and get this. Working where I am, it's all a paper, which is often with the nurse's notes. The completion of this is variable, so if it's important, such in this case, you need to make sure that as well as writing in the plan of doing a strict input-output, you also let the nurse who's looking after the patient know, and in some cases a catheter might be appropriate. So, for example, in this lady, she's had 2 litres of IV input, her output is 1.5 litres. You're seeing and then that's your fluid balance, and then you're doing your clinical assessment. So you can either do this part of the exam or do it separate to come showing how you've come to your conclusion. So JVP's down, no edema, cap refill was just on the borderline 2 seconds, but our mucous membranes appear dry. So we're thinking this lady is hypertensive because of essentially being underfilled or hypovolemic. So hypovolemia or this underfilled status doesn't necessarily mean that there's not enough fluid on board, but it's just not in the right spaces, it's not circulating around. So in this patient, we're thinking we need to start some fluid resuscitation. So the initial bolus you may know is sort of 500 mils IV fluid going through stacked crystalloid Hartmann's or saline. That will also depend on the degree of the hypovolemia and also the weight of the patient as well. So in ED, sometimes you see if a patient comes in who's young, very unwell, they might just put a litre up and push it through because they can tolerate that. If you're putting a sort of a 95-year-old and a little bit hypertensive, then a 250 bolus might be a better place to start if the degree of hypovolemia isn't extremis. So the important thing is that this is often difficult if you're getting called away is to reassess, and depending on where you're working, the obs charts can be online in a lot of places, so you can make sure that the nurses, you have a plan to reassess the patient. So this can, if they're a little bit hypertensive, you're giving a bolus, and then you also want to think about prescribing some maintenance fluids or continuing to fluid resuscitate them, but a bit slower. So you might write up your 250 bolus and then write another bag after that, for example, 6 hourly bag. And you're wanting the nurse to say, when that first 250 ml or 500 ml finishes, can you repeat the obs and put them on the system for me? Because that means even if they're a little bit hypertensive, say it's 110 or something, and you've given them a 500 ml bolus and prescribed a 6 hour bag, but then you're called to a sicker patient, you can say, can you put the obs on after you're done, and I'll have a look. If it doesn't pick up or it's getting worse, call me back. And that allows you to look remotely and sort of reassess that fluid bolus and know that you've prescribed some continuous fluids. It will buy you some time. It's all about trying to be sort of proactive in terms of maintaining and managing your time best. So when we're looking at hypovolemia, obviously this is a deteriorating patient, we need to think about escalation criteria. So if this patient is very low blood pressure or it's dropping rapidly, or in some cases you might get unreportable blood pressure, then obviously you need to put out an immediate sort of 2222 call, and you need help. You'll need the help because you'll need assistance of doing things that you can't just one single pair of hands. It's not that you certainly can't know what to do, but you'll just need more hands in doing it. So this is like getting a wide bore access, putting up more fluids, and potentially heading towards a peri-arrest situation. The other aspect is this idea of refractory hypertension. So if you've got someone who's very septic and they're severely vasodilated, then sometimes you can be putting a lot of 2-3 litres in them and the blood pressure is still not coming up. At this point, you need to think about where your map is at in terms of your mean arterial pressure, and if the map is not responding to the fluids, then you're going to start getting end organ damage because you're not providing that perfusion pressure. And this is the time you need to think about whether these patients are for escalation, and you need to be thinking about getting your ITU colleagues. If you're putting some fluid in and you're not getting a response, that's the time to start escalating up. And I'd have obviously at that point, calling your registrar, and then they would often come and see the patient and then ring ITU, or they might ask me to ring ITU depending on where you are. So we also think that we've got to think about what else we could try. So fluid is the thing that springs to mind when you see someone with hypertension, but it's not the answer for every hypertensive patient. So it's important for it not to be a knee-jerk reaction and I'll give a fluid and then we'll see what happens. We have to think about the case itself. Obviously, if they're hypertensive, and then in most scenarios, nearly all, then starting fluids in that initial hypertensive phase will not is probably sort of a safer option if it's not entirely clear where the cause is coming from. But you also need to think about what additional treatments might be needed to help. So it really depends on what the driving factor is hypertension. So for Sarah, we need to be thinking about why she's hypertensive. So this could be hypertension solely secondary to volume loss in terms of the diarrhea and vomiting. But we also need to think about the case itself. So could she be sepsis? Could this be something that's causing a vasodilation response? Or could it be something else? For example, could this be an Acidosis crisis? So if she's been having diarrhea and vomiting for several days, and she's normally on prednisolone for her PMR, she hasn't been able to take it, she's got reduced oil intake, then that would make us think that she needs to have some IV steroids, because she might be going into an Acidosis crisis from that perspective. So it's all about having a think about, is there anything else in this case that would make me think about an alternative or an additional driver of this hypertension. So in this case for Sarah, when we think about fluid resuscitation, hydrocortisone, correcting her hypokalemia, and then plus or minus antibiotics. If she's already on it, then we can continue it for now. So when we're looking at hypertension, we've largely talked about hypovolemic hypertension, but there's 4 main categories of hypertension. And we're thinking here, we're going back to our sort of physiology, our pathophysiology, that the blood pressures can use your cardiac output and times your systemic vascular resistance. So where you've got a drop in, and obviously cardiac output is split into your heart rate times stroke volume. So if you started getting one of these numbers dropping lower, then your blood pressure overall is going to start dropping. So we talked a bit about hypovolemia, but it's not always going to be when you're losing something in the body, you're not losing fluid, you'll be losing blood. So if you're losing volume extravascularly or extravasating in effect, then you need to be thinking about what history could make me think about this patient could be losing blood. So you need to think about whether they're checking for melena, do they have a history of cirrhosis, is there known varices, have they had a previous OGD that's confirmed this, and they have previous banding. Obviously, you're not going to have blood available immediately. Even if you put out the major hemorrhage protocol, you're not going to have that blood as fast as you're going to be able to have fluid. So start fluid first and then start preparing to get blood. If the blood loss is severe and they're developing shock, then obviously that's when you want to be escalating to a major hemorrhage protocol, and that's when you'll be thinking about putting out an emergency call as well to get help. So that's hypovolemic shock, but also need to think about distributive shock. So this is things like sepsis, but also an allergic reaction. So you have a think about looking at the drug chart as well. So you don't obviously have to, if the cause is clear and the patient's got a pneumonia and they've been hypertensive, come in and it's sort of on the borderline, you've got to be pragmatic in your response. But if it's not really clear why this patient's become hypertensive, you need to have a think about what are the other driving factors. So has she been prescribed tazocin, but she's got a penicillin allergy, and now she's developing an allergic reaction to this. So, and then I've mentioned that not all hypotension is hypovolemic. So you can have cases that can be euvolemic. So these will be things such as cardiogenic or obstructive causes. So these would be things like tension pneumothorax, so you might be in the mediasternal shift blocking your output. PE, if there's a large saddle embolus, for example, you're going to start getting hemodynamic instability. Certain arrhythmias, either too fast or too slow, will interrupt if your heart rate goes too fast and there's not enough time in diastole for the ventricles to fill, and you're not going to get enough cardiac output. And then another sort of just to touch on is decompensated heart failure. So this is a tricky one. So you will get patients in sort of end-stage heart failure who will become hypertensive in the fact that this is when their stroke volume can't keep up, essentially. And at these points, when you're starting to get hypertension in heart failure, the prognosis is starting to not be as good, and you need to be clarifying escalation status. Because if this is an event following MI, with an MR, for example, then you need to be thinking about what acute escalation might be needed, and this patient might need escalation to ITU for sort of vasopressor inotropes. But it's important to have a think, because in these cases they're going to likely be hypovolemic with a large amount of extravascular fluid. So giving them fluid may only lead to a transient response to their blood pressure, or sometimes no response at all. So you have a think about what is our trajectory and what is our aim to treatment. So in essence, as I mentioned, hypotension is hypovolemic, distributed cardiogenic, or obstructive. So have a think about which of those is you're most likely in your history, and sort of go forwards from there. You can obviously use fluids in the vast majority of cases initially, but have a think as well about what other treatments might be needed. So we're also going to talk about hypertension. It's not so much as in the deteriorating patient. It was something that was mentioned in the talk brief. This is not so, as I mentioned, not so much deteriorating patient, but it's quite a common call for FY1s on the wards. I remember being called for it quite a lot, and as a registrar now, the F1 are asking me for advice about what we should do with this patient who's got multiple allergies, who's got a blood pressure of 170, 180 or something like that. So when you're approaching hypertension, you need to think about, there's three aspects that I like to think about the urgency of treatment. So it's going to be the degree of the hypertension, any evidence of end organ damage that's being caused, and then finally, is there any underlying driving factor or cause for this hypertension that we need to think about treating, or is it just idiopathic hypertension? So splitting this down, we're looking at the assessment. So we're looking for end organ damage. So these are going to be sort of like your history examination and investigations. So with a patient, when you're called to see a patient with high blood pressure, for example, say their blood pressure is 190 or 200 systolic, you need to do a bit of an approach to what's going on. The nurse might just call you about it because the HCA has done the obs and this is what it's shown, and she's told the nurse and the nurse has escalated to you. But it's important to just get a quick history from the patient. It doesn't have to be a history as in a clerking history, but just a minute conversation of how are they feeling. Often they'll just have no idea their blood pressure is that high, but you've got to try and make sure they're not developing any concerning features such as chest pain, headaches, or visual changes. You'll be looking at the examination and then investigations. So these, depending on how high the blood pressure is and how long it's been high, you'll be wanting at some point to have had an ECG, Usinese. So if they had Usinese that morning and their blood pressure has been high all day, or it's gone up by 10 millimeters of mercury, you don't really need to repeat the Usinese. But often these patients won't have urine dipped, and it's quite important from a sort of a renal perspective, if they're developing any renal impairment, that a urine dip is done. Obviously, you're not necessarily going to get that immediately, but you're going to ask the nurse to do it. So then you want to be thinking about, as I mentioned, what's the driving factor. So is any clinical diagnosis that's suspected that needs urgent blood pressure control? So have they started complaining of chest pain, radiating through to the back, and the blood pressure is very high? Then you can be thinking about, is this a dissection that's led to this hypertension, or is it something like an acute MI? Then you want to be thinking about some of the more common causes, and these will be things like just missed antihypertensives, for example. This could be either through a prescribing sort of error in inverted commas, and the fact that they didn't know what medications they were on, so they've just come in the night before, they've been clocked in, and their ramipril and their doxazosine is being missed off the chart because they didn't know what they were on at the time. The pharmacist may have written it in the notes now, but it hasn't been put on the drug chart, so that could be a very easy fix. So it's not come up with this is hypertensive urgency. For some reason, it's not come up with the title, but there's variable definitions for hypertensive urgency and hypertensive emergencies. So there's variable definitions for this. So an emergency, broadly speaking, is if it's above 180 over 110 or diastolics above 120 with evidence of end organ damage. So then you'll be wanting to look at your hospital policy, and most hospitals do have policy about what is the preferred agent to start with and how do you titrate this up. So GTN or labetalol are quite often used, and there normally be quite a well set out guide on how to start it, what dose to put in the syringe, and how fast to start it and to titrate up according to response. In terms of hypertensive urgency, where you've got someone who's got a high blood pressure, but there's no evidence of any organ damage, they may be asymptomatic and completely fine, then there's not very good quality evidence on how quickly to bring the blood pressure down. You'll probably see much more hypertensive urgency than you will some hypertensive emergency. So in urgency cases where, for example, the blood pressure might be sort of 178 over 106 or something like that, or perhaps higher but no evidence of damage, then you'd be wanting to bring the blood pressure down over sort of hours, days. You don't want to be rapidly lowering it. So there's a few different methods how you can approach this, and again this goes back to sort of pragmatic medicine rather than sort of, so you'd be thinking about, are they known antihypertensive, and if it's 3 o'clock in the morning and they're known antihypertensive and they've got amlodipine that's going to be given at 6 o'clock, you can just ask the nurse to give it early and assess the response to that. Perhaps they've had their dose early in the day, and you might consider giving them another dose if they're on doxazosine and they've had they've had a dose in the morning. You could always give another dose if you're being called in the evening about it. And failing that, amlodipine is often, obviously, the majority of the patients you're going to see in hospital will be above the threshold for NICE criteria in terms of you'll be starting a calcium channel blocker first, unless there obviously other impacts such as diabetes, but amlodipine is quite a good initial one. You've got to be a bit wary that obviously if you're giving amlodipine, it takes time for it to work. So if the nurse calls you an hour later and says, "Doctor, the blood pressure is still high," you've just got to explain that the amlodipine will take time for it to work, and you've got to give it a good sort of 6 hours for it to have a good effect. Or I mean, it's a little bit faster than that, but you've got to give time for the amlodipine to work before you consider giving any other antihypertensive. So we'll move on to a second case now. So this is Mr. Jones, 52-year-old man being treated for pneumonia. I'll just let you read that quickly. So essentially a 52-year-old man with pneumonia, background of bronchiectasis, hypertension and BPH. His obs show that he's desaturating essentially on 5 litres of oxygen with a high respiratory rate. So how are we going to assess this patient? So initially we're going to increase the oxygen flow. We need to give this gentleman more oxygen. At the moment he's hypoxic on his peripheral SAT, so increasing the oxygen flow and changing the mask accordingly. Obviously there's certain masks, like a simple face mask, if you increase it up to 15 litres, it's just going to blast a lot of the air around the face mask. So you have to use the appropriate mask with the appropriate amount of oxygen. Obviously, if you're well known, your A2E assessment, if you've got a critically unwell patient, starting on 15 litres initially whilst you do your preliminary assessment and get a bit of a history, even if you're putting them only on for a couple of minutes, unlikely to cause any sort of significant harm from that perspective. You'll be going for your A to E, so obviously we're looking for any airway problems, so occlusions, high level secretions, same for your breathing, and then as Chris mentioned, sort of do your A to E before you do your ABG, but if you've got additional hands that while you're doing your examination, someone can be looking at doing the ABG. And then you'd be looking at things such as a chest x-ray. So if you've got an unwell patient, these might be times where you're considering contacting radiology and asking them to come down to the patient as a portable chest x-ray, fill out the form whilst you're there, and then essentially hand it to them as they arrive, essentially. So you can get an x-ray done sort of within 15 minutes if you call them and arrange it to be done portably. And then you've got to think about what interventions can we offer for this tachypneic patient. So when you examine him, he's got coarse crackles at both lung bases, particularly on the right, which do shift a little bit on coughing. There's no wheeze that you can hear. So we're thinking about what we could offer this gentleman. So obviously oxygen is going to help, and we're going to titrate that up according to his SATs. Then you want to be thinking about what do you have in your arsenal that you can be used to treat this gentleman. And this is where you've got to have a think about the few different things that you can be used in different situations that will help. A lot of these treatments have sort of very little harm if they don't help, so they're worth having a go if you're not sure what's going on. So saline nebs in this gentleman might be quite beneficial. So if he's got crackles that are shifting on coughing, and he's got a background of bronchiectasis, then if he's got a good cough reflex, then, or he's got a good strength in his cough, rather, I should say, then saline nebs will help mobilize some of that sputum and mobilize some of that mucus, and he'll be able to expirate it a lot easier. Mucolytics, so obviously these aren't that useful in the acute phase, but are something that you can be used for going forwards and helping. Carbocysteine is obviously quite used, but we are seeing more recently an emergence of erdostine, sort of short courses to help with that. Chest physio, so these you often will have depending on your working, you'll have chest physio, whether they're on call 24 hours or whether they're on call in a day, but they can be really helpful in trying to shift some of the mucus and help them to patients to expirate and give them breathing exercises. And they are, as well as sort of physio being used in terms of sort of in the day, in terms of sort of getting a patient a little bit better, they can also be very effective in the acute setting as well, in terms of helping a patient who's acutely unwell. So don't underestimate their use. And then you're thinking about other things such as escalation of antibiotics and looking at their biochemical response and their clinical response, and whether the current antibiotics for pneumonia aren't working, you need to think about going up. Obviously, this doesn't treat the desaturation immediately, but it's all part of your arsenal of what you can offer. Often other things you could think about in terms if there was wheeze or things like asthmatics is obviously your nebulizers and your steroids from that perspective. So as I was mentioned, what's driving the breathlessness defines the treatment. So if you've got airway narrowing, so you're getting developing wheeze, this is when your nebulizers and your steroids will help. So you need to consider an allergy also driving the airway narrowing, not just asthma. If you've got alveolar congestion, for example, and pulmonary edema, then this is when you be thinking about diuretics. And be wary that sometimes wheeze can be cardiac asthma, and so to speak. So you might get some wheeze even in a patient who is hypovolemic and has pulmonary edema. So will sort of need to be wary of that and sort of tailor your approach, but bearing in mind the history as well and the past medical history. If there's a lot of crackles going on in the chest and they've got a background of sort of a suppurative lung condition, for example bronchiectasis, then saline nebs and physio mucolytics, as we mentioned, can be quite effective. If their chest sounds very clear, but they're hypoxic on oxygen and they've got a high respiratory rate, then you need to be thinking about, could this be a perfusion mismatch? And this is where you'd be thinking about something like a PE, especially if it's quite a rapid deterioration of a normal chest X-ray and normal examination. But also you need to be thinking about, could there be a non-respiratory driver? So if you look back to sort of the AT and your OBS, respiratory rate going up slightly is often one of the first part of your parameters in your news chart that will change when you've got an acutely unwell patient. So it could be a completely non-respiratory based problem. You need to think about, are there any other sort of non-respiratory drivers, that more specifically, that might be driving this patient's tachypnea? So these could be things such as a metabolic acidosis. So in AKI, if you started accumulating acid, then you're going to try and compensate by hyperventilating and blowing off your CO2 to maintain your pH in sort of normal homeostatic range. So you might be thinking about, as part of your ABG, or you'll be having a look at the bicarb and seeing what the bicarb is doing, and as Chris alluded to, having a look at sort of analysing it in terms of where is the acidosis coming from. And other causes might be things such as anemia. So could the respiratory rate be up because on the gas their HB's dropped from 110 to 72? Obviously, at that point, it's important to check that you haven't taken your sample from the drip arm. But if it's a true reading, then you're leaning towards the fact that this tachypnea is probably part of the anemia, and the fact that they're not getting an oxygen around because they haven't got enough red cells to carry it. So move on to our third case. So again, it's you was working as a ward cover on the night shift. So Miss Smith, a 62-year-old, admitted with malaria. So she had an OGD. It shows a peptic ulcer. The nurses are concerned that she's tachycardic. Her obs, tachycardic, blood pressure is okay, and all the other parameters are all right. So how are we going to assess this patient? So this is where sort of a bit of advice is, obviously if a patient is tachycardic and the nurses ask you to see them, then obviously you can ask the nurse to do something for you whilst you're coming to see the patient. So they ask you to see the patient, even if it's not something that you need to come urgently for. Say if it's not that, say it's 110 or something, they're completely otherwise fine. It's been 110 for a while, or it's up and down. You can ask the nurse, to perform an ECG for you, so you'll have that at the ready, essentially ready for you to read when you arrive at the bedside. And also an ECG will provide a much more accurate reading or recording of what the true heart rate is compared to the sort of the OBS machine and the SATS probe that will be picking it up. You need to prioritise depending on the rate and also the presence of adverse features. So some people will not tolerate the same degree of tachycardia than others will. So, for example, if they're young and they're normally fit and well, then sort of a heart rate up to 150 won't they can be batting along and be fine. But other people who don't have the same physiological reserve or have other comorbidities won't be able to tolerate that same rate. And obviously, if the rate is very high, then that is another sort of alarm bell ringing in your head that you need to see this patient rather urgently. So if they've got extreme tachycardia or there's adverse features present, these are things that going back to your sort of ALS algorithm, then you need to be putting out the emergency bell. These are patients may require things such as cardioversion or adenosine for SVT treatment to delineate what the underlying rhythm is from that perspective. If you don't need to put out the emergency call, but you'll be going through your normal A2E assessment and looking at their sort of cardiovascular status. So here's an example of, for example, in this patient, what their ECG shows. So I hope you can all, just from the sort of a brief glance at it, you can see that the rate is irregular. So this will be consistent with diagnosis of AF with a fast ventricular rate. So how are we going to manage these patients with tachyarrhythmias? So in this patient or another patient, well, this is atrial fibrillation, but sometimes it can be quite hard to tell between atrial fibrillation and atrial flutter, especially if it's quite fast. Atrial flutter often will, depending on the block, be around sort of 150 beats per minute, but you can have sort of slightly more complex cases where you might have atrial flutter with a variable block, or if it's so fast that you can't really tell the difference. You need to think about what is the driving factor. So it's important not to start tunnel visioning into its AF. My treatment options here are, do I give Bisoprolol or do I give digoxin? Because that, in this setting, is not probably the best thing to do first for this patient. So you need to think about what's the driving factor. If this patient wasn't in AF and the heart rate was still the same, you would approach it completely differently. So you need to think about from that perspective as well, but why are they tachycardic? Are they tachycardic just because there's an ectopic in the atria and that's developing atrial fibrillation? That may be the case, but are there other factors that you need to consider? As I mentioned, thinking about beta blockers and digoxin, and then if it is AF and there's not another driving factor behind it, you'll be thinking about commencing either beta blocker or digoxin with sort of taking into account variable factors, and then reviewing for further doses after this. So obviously digoxin is a loading, so you need to load the patient with a dose of digoxin depending on their weight and the other factors, renal function, etc. And then you need to reassess after about 6 hours and then continue loading them as per BNF until the rate is controlled For beta blockers, it's not so much a loading, but you still need to make sure that you're assessing the response and giving another dose if needed, if there's a poor response. If it's sort of 6 o'clock in the morning, 5 o'clock in the morning, and you've got someone with atrial fibrillation, and you're not sure about anticoagulation, you can, if you've got the time, obviously doing the CHA2DS2-VASc and the orbit score is useful, but it doesn't have to be a decision that you have to make there and then, because it should be a decision that takes into consideration all the outside factors that from the day team that will know the patient, and also a decision that's made in collaboration with the patient. And sort of 6 o'clock in the morning when they've been fast asleep might not be the best time to start talking about long-term risks and benefits of anticoagulation. So in Miss Smith's case, for example, you do a BBG and you find out that she's got a drop in her hemoglobin from 92 to 71. You send off lab bloods as well just to confirm this biochemically. But in this case, giving her a beta blocker or a digoxin, although on paper is obviously one treatment for AF, wouldn't be the first protocol, and I probably wouldn't be giving it initially until I've tried with volume resuscitation with fluid and blood. I think would be my main aim, because this case would fit more with someone who's hypovolemic, that's driving a physiological tachycardia response that means her heart rate is high, rather than it being purely the AF on itself. So you'd have a think about what is the driving factor. So this patient, we're going to give them fluid to start off with, and then blood after that when you can get the group and saves off. So if someone is, for example, septic and slightly hypertensive, then you don't want to be suppressing the heart rate with beta blockers, because what you'll be doing then is you'll be suppressing someone's physiological response. So in these cases, you almost want to treat them as if it's a sinus tachycardia, and treating them as if you would, if that was the case, with sort of volume replacement, and then going forwards from that perspective. And I'm just going to touch lastly just a bit on sepsis 6 in practice. Obviously, we know our sepsis 6, and I'm sure you've all learned it from your medical school. Obviously, the first aspect of it is oxygen. Blood cultures, very useful, taken early, and will immensely help your colleagues down the line, and also obviously help the patient as well. If you can identify the bulk that's grown, you can narrow down your antibiotics much more quickly. But it's something that you're doing for the future benefits rather than today's benefits. Some microscopy can suggest the source. So if you're looking at a cockeye, for example, but you won't necessarily be able to tell what it is, and normally it would be awaiting further sensitivities. Either your antibiotics, so when you start work, you all will get sort of on hands or get to grips with the hospital policy, and these do vary quite a lot trust by trust. So where you've been in your last placement may vary quite a bit from where you're currently working now, or where you will be working, and it varies a lot on what the local resistance is. IV fluids, and as we mentioned before, a lot of importance is on frequent assessment, and making sure that the effect is sustained. Urine output, so this is where you'd be aiming for sort of a minimum of 0.5 mils per kg per hour. And you can look at sort of the areas, I think it's the KDIGO classification for AKI, or it might be the VIFO, I can't remember which way around it is now, one's for sort of your criteria of AKI in terms of what the urine output is just as important as some of the biochemical features. And then your lactate. So this is raised, and it's often done when you're putting the cannula in. You put the cannula in. You might take the bloods out for sort of a VBG and send off with a full blood count, use needs, etc. So you shouldn't be taking blood cultures from the back of a cannula. But when you're doing the other results, then you'll get your initial preliminary lactate result, often sort of done before any treatment's done. So if it's high, then you need to make sure that you've got a plan in place to repeat it, to make sure that whatever you're doing is helping the perfusion. So just to touch a bit on lactate. So what is lactate? So it's a product of anaerobic glycolysis, and it's produced when you don't have enough oxygen, so you have to respire anaerobically, and then it's metabolized largely by the liver and the kidneys. It goes up, there's excessive production, or there's impaired clearance. But there is a large reserve for clearing lactate in both your liver and your kidneys. So that is a very much more a minor. Obviously, what goes in must come out, but you do have large reserves for doing that. So shouldn't be the first thought. Generally, depending on your values, but mostly if it's above 2, then it's raised essentially, and it does have quite useful prognostic value. So the levels are going sort of much higher, and then sort of towards, I think there's on the studies if it's above 8, then it's associated with a high mortality risk. So there's 2 types of lactic acidosis. The latter one being sort of a bit more niche, but your type A lactic acidosis is due to your impaired oxygen delivery, leading you to respire anaerobically. So what are the settings could this be? So this could be either being developed by the muscles. So in the case of seizure, doing a VBG after a seizure to confirm that the event, obviously it can go up if you're exercising from a sort of a non-epileptic attack, but won't be so, not always be quite as high. Tissue hypoperfusion, so this can be generalized or focal. So in sort of we're thinking about generalized hypoperfusion, this is sort of the septic shock perspective, or hypovolemic shock. But you need to remember that lactate can be produced by lots of organs and lots of areas. So even if there's only one area that's being hypoperfused, that will still leads to a very high lactate that will circulate around and just be picked up. So when you measure a high lactate, you don't know where that lactate's coming from. So you need to be thinking about focal causes, and sort of a big one is sort of mesenteric ischemia. So if they've got a very high lactate and you're not very sure where it's coming from, then have that in the back of your mind. So it might not necessarily be a hypoperfusion in terms of the actual blood's getting there, but it might be that the oxygen is not getting there, so you can't respire aerobically. And these are the things such as anemia and carbon monoxide poisoning. And then finally, sort of a bit more rare is your type 2 lactic acidosis. This is sort of more for completeness, but these are sort of certain conditions like lymphoma, leukemia, some of the organ failures, and then finally sort of drugs. If you've given someone a lot of salbutamol, then they can develop a slightly raised lactate. And then I know Chris has mentioned this as well, but we'll just talk a little bit about escalating and about sort of how you put SBAR into practice. So personally, when I feel when someone's calling some for advice, then I think a good way is to slightly modify your SBAR, because SBAR is really sort of used for a handover. But when you're escalating up to the reg or to the SHO, then you want to sort of, I think, get to 2 points across essentially. So you really want to be almost changing your SBAR from SBAR to SRBA essentially. So what you're really wanting to do is put your situation and recommendation quite soon on. So this sort of is quite wordy. You ask you, this is your SBAR sort of way. So you're saying they've got chest pain, background is pneumonia, antibiotics. This is what's going on. This is my assessment, their OBS and my examination. And then you say, would you give me some advice or review? So it might be that if you wanted them to have a look at the ECG, or for example, then it might be easier to say that at the beginning, because they might say, okay, if you bring it to me, we can talk about it there. But when you've got other cases, you might want to swap it around to make it a bit more prominent. So if you're worried about someone I've just seen with chest pain, I'd like to review his options, has risen up quite significantly. And then they might sort of ask you a few more questions about, or say, tell me a bit more about the case. But I think there's sort of broadly three categories about why you'll be ringing the registrar. One is you're with a sick patient and you need help, in which case starting off with saying, I've just seen someone who's got low saturations and low blood pressure. please could you come and help, because I'm not sure what to do next, or I need another pair, or I need some more support. And I think that's quite useful. They might ask, say, what's the blood pressure, what's the SATs, because they might be in resus, and they just want to know to prioritise, do they go themselves or do they send the SHO? But I think a succinct aspect of that, you don't want to be going into lots of their past medical history as this is what my examination was, because you're going to be needing them there, and the more time you're spending over the phone, the longer it will take them to get there. So if you want them to be coming because you're with someone sick, get that point across early, because a lot of the time it's easier for them to make their full assessment when they're there with you and you can go through things together. That's one of the reasons why you'd be calling the reg. The other reason will be for advice. So again, that's probably best sort of if you're doing the spiel from the top, then the person at the end of the phone doesn't know what points they need to be picking out, because they don't know what question you're going to be asking. So it's quite good to say something like that. I've been asked to see someone with, for example, chest pain, and the troponin is this, and then you go about, he's had chest pain for this long, and this is what the ECG shows. Do you think I should give them aspirin now, or do you think I should wait for another? I want to ask, should I give them aspirin now, or should I wait until I've done the second troponin, for example? And then you go into the history and tell them why. And then the reg will be thinking about, as you're going through, what points do I need to pick out about what will help you make my decision, rather than doing it the other way around and then the not knowing what you're going to ask until the end. And then the third sort of reason why you might call the reg is for an investigation interpretation. So, for example, a chest X-ray or an ECG. And again, then it's quite important to, I think, to tell them that at the beginning. So to say that I'm with someone with chest pain, they've done an ECG, and I'm not sure whether there's some ST depression in some of the lateral leads. And then you might tell them about the chest pain, the background, and the password, because they might just say, "Oh, I'm in resus. Could you bring the ECG to me?" And you look at it together. Or you might say, with someone who's short of breath, I've just done a chest X-ray. Do you think there's this? And I'm not sure there's a small pneumothorax. And then they can load up the X-ray, and you can talk through the case about, they've got a background of COPD and they had a previous pneumothorax 2 years ago. And it just helps the thinking process from the other end. But I think the main part from that is that if you want someone to be coming to help you, it's important to get that across early, so that you're not spending a lot of time talking about the case to then ask them to sort of come anyway. So it's important to get across the urgency that you want help and who you want help from. And I'm sure they'd be willing to come and help you with that patient. So that's pretty much a whistle-stop tour of deteriorating patients, a bit tagged on the end. I hope you found that useful. I think hopefully Chris should be here as well in the background, so welcome to answer any questions from either talk. I will load back up. I'll close down my screen, but I will look through the chat if there's anything that's come through.
Thanks very much for listening, guys. I think there was a question actually while you were talking, Chris, from George, who was asking, when you were talking about patient with hypertensive urgency and doing the urine dip. And you're right, George. Yeah, the reason for doing that is to look for proteinuria, which can be a marker of end organ damage, acute renal failure.
Often the renal team will like, so if you do see proteinuria in the urine dip, then the next step would be looking at doing sort of an ACR, sending off an albumin creatinine ratio or a protein creatinine ratio off to the lab. Obviously, that takes a bit more time, but it will help your work up in terms of sort of the end organ damage to the kidneys.
All right. Thank you for this very informative talk, Chris, Peet, and Chris Penney. So now we'll have the Q&A session. So guys, just put your questions in the chat. Any questions for Chris? We have two very experienced medical registrars. Any questions at all about what you would do as an F1 or anything about life in as an F1 in general? You want to ask Chris, Peet, and Chris Penney, and they'll do their best to answer it.
George, for the urine dip, I wouldn't normally do the urine dip myself. I would normally ask the nursing team to do it.
However, sometimes if you want something doing quickly, doing it yourself.
Yeah, it is a difficult balance. Obviously, you are obviously a resource that you might be covering a lot of the other wards, and like I said, it's not a test that needs to be done that minute in a lot of cases, but it is important to not just jot it in the notes. It's important to actually tell the nurse looking after the patient, can we do a urine dip on this patient when you get a chance, rather than sort of what you don't like to see is when they're just written in the notes, and invariably that it will never happen.
And just a reminder in the meantime to do fill out the feedback forms at the end using the link posted in the chat. You'll get a certificate of attendance you can use for your portfolio as well. So yeah, just put some more questions in the chat, guys, if you have any more questions for our medical registrars.
Stun them to silence. It is quite late.
Yeah. I'm not sure that's exactly. I'm not sure that's a good sign.
Coming to listen to this talk until 9 o'clock at night.
So we have one question. Can Medall talks be counted as part of your portfolio? So yeah, part of the FY1 Survival Guide series, you can use these as non-core teaching hours. So you can use your certificate of attendance as proof. So it can count as non-core teaching hours for attending these talks. Any more questions at all? Or anything about F1 life or F1 situation you'll deal with? Oh, yeah, we have a question. How do I manage a patient who is not responding to voice or pain, but airway is patent and breathing, and they're breathing not okay?
I'll take that one. So I think the important thing is obviously, like you would do with everyone, so that the airway is patent, so that I presume means there's no airway noises. So you want to figure out why they're unconscious, because that's not normal. Common things, so hypoglycemia, always important to check for that, even in patients who aren't diabetic. And then looking at medications, so has this patient been given opiates, and particularly if in the context of, often you see patients who have come in acutely unwell and they've got deranged renal function and they've just had their routine, long-action morphine prescribed like Zomorph, and this will be accumulating and causing toxicity. So always important to check those sorts of things out. Is there any history that might suggest they've had a seizure from the nursing staff, or are they known to be epileptic? So all of these things are important to look into. In terms of how you manage it, it's important to not just dismiss it. So often it can look reassuring if all of their vital signs are fine. And Chris will probably agree. We see a lot of these patients in elderly care. They just become unresponsive, and sometimes it can be a hyperactive delirium. But it's always important. They probably need some imaging of their brain if they've not had imaging of their brain, to make sure they've not had an acute bleed or something that might be making them unresponsive. So I would say do your initial assessment, and then speak with your senior about arranging some imaging and proceeding based on what you found.
I think that pretty much covers how I approach it as well. I think, like you say, the drug chart is often an undervalued resource in your assessment of the patient, and you need to be thinking about not only sort of additional drugs that have been given, but the other physiological parameters, as Chris mentioned, that might change, so that even a normal dose drug or a drug that had been on for a long time may have quite an impact. So the toxicity is not necessarily due to the increased dose, but might be due to the reduced clearance.
Any more questions at all from the audience? This talk is also being recorded and will be available to view on the Mind the Bleep YouTube channel. So I think that's all the questions we had for today. Thank you, both Chris's, for this very informative talk.
That's good.
Thanks for asking us to come and talk. Good luck with your F1 placements, everyone. And yeah, maybe see you around on the wards. All right.
Thank you.
Thank you. Okay.